Welcome to Humanautic, unlocking the secrets inside your body and brain. Today I will be explaining how to perform an open cholecystectomy, step by step, in a clear and structured way for surgical students. An open cholecystectomy is the surgical removal of the gallbladder through an abdominal incision. It is indicated in cases such as symptomatic gallstones, acute cholecystitis, empyema, perforation, suspected malignancy, or when laparoscopic surgery is contraindicated. 1. Pre-operative preparation. Before surgery. Confirm diagnosis with ultrasound. Check liver function tests. Ensure coagulation profile is normal. Start IV fluids. Administer prophylactic antibiotics. The patient is placed in the supine position under general anesthesia. The abdomen is cleaned and draped in sterile fashion. 2. Incision. A right subcostal incision, also called Kocher's incision, is commonly used. The incision is made approximately 2 to 3 centimeters below the right costal margin. We incise layer by layer. Skin. Subcutaneous tissue. External oblique. Internal oblique. Transversus abdominis. Peritoneum. Bleeding vessels are cauterized carefully. Once the peritoneum is open, retractors are inserted to expose the operative field. 3. Exposure of the gallbladder. The liver is gently retracted upward. The gallbladder is identified. If inflamed, it may appear distended or thickened. If tense, it can be aspirated to decompress it. Adhesions are carefully dissected using blunt and sharp dissection. Now we expose Calot's triangle. Calot's triangle is bounded by the cystic duct, the common hepatic duct, the inferior surface of the liver. This is the most critical step of the surgery. 4. Identification of structures. Careful dissection is done to clearly identify the cystic duct, the cystic artery. We must achieve the critical view of safety before dividing any structure. This means only 2 structures entering the gallbladder are seen. The lower third of the gallbladder is separated from the liver bed. Never clamp or cut blindly. 5. Ligation and division. First, the cystic duct is isolated. 2 ligatures are placed proximally and 1 distally. The duct is divided between the ligatures. Next, the cystic artery is identified, ligated, and divided. Extreme care is taken to avoid injury to the common bile duct. 6. Removal from liver bed. The gallbladder is dissected off the liver bed using electrocautery or blunt dissection. Small bleeding points are controlled immediately. Once fully separated, the gallbladder is removed. The operative field is inspected for bleeding, bile leakage. Irrigation with warm saline is performed. 7. Closure. If required, a drain may be placed in the subhepatic space. Closure is done in layers. Peritoneum. Muscle layers. Fascia. Subcutaneous tissue. Skin. Skin is closed with sutures or staples. A sterile dressing is applied. 8. Post-operative care. Post-operative management includes monitoring vital signs, pain management, monitoring drain output, watching for complications such as bile leak, infection, or jaundice. Early ambulation is encouraged. Complications to remember: hemorrhage, bile duct injury, bile leak, wound infection, retained stones, subhepatic abscess. Thank you for watching, and subscribe to Humanautic for more high-quality surgical tutorials.